so lucky to be joined by two incredibly special guests, Dr. Matt Semler and Dr. Nicole Acquisto. Now, Nicole is a professor of emergency medicine and a clinical research pharmacist at the University of Rochester Medical Center. And a reason she's here today, of course, chair of the 2023 SECM RSI guidelines. She didn't include on her biography that she's a previous Pharmacy to Dose Award winner, but we'll add that while she's on the pod here. And Matt is a professor of medicine, anesthesiology, and informatics at Vanderbilt University, working in the medical ICU, directing the Center for Learning Healthcare, and helping to lead the Pragmatic Critical Care Research Group Clinical Trial Network. And of course, that leads to the big reason he's here today, senior author on the 2025 New England Journal of Medicine article, Ketamine or etomidate for tracheal intubation of critically ill adults, aka the RSI trial. Nicole and Matt, welcome. Thank you so much for joining in the new year. How are you both doing?
Great, thank you. Thanks
Hey,
for having us.
thanks so much for having us. Looking forward to it and doing well in 2026.
It's crazy, right? I like that five can be easily corrected into six. Like it's way
Right.
easier than the 4 to 5.
Yeah,
Um,
that's been relevant.
Now, Matt, I have to bring up right the RSI trial. It's been out for about a month or so. And a lot of the when I kind of doing a little background research and things, the first author, Dr. Casey John, is certainly getting a lot of the clear interview requests. So I'm glad that we were able to bring on the senior author, get a little different perspective. But in all seriousness, thank you so much for joining and kind of talking through what is an incredibly well done and awesome study.
Yeah, no, I'm so glad to have the opportunity to not to be listening to John's voice anymore. I think we all are. But no, I'm thrilled to be here.
So we have to start. We got to get everyone on record. I'll go as well. So prior to starting this study, right, or learning of its results, maybe an important caveat. What was your standard or preferred RSI regimen, right? What was everyone's favorite, right? Like to me, probably not the favorite for everybody, but my go-to is etomidate and rock, I would say is mine. We'll kind of pass the buck. Nicole, what was yours?
Yeah, I mean, I've kind of gone through the pendulum. So when I started clinical practice about 20 years ago now, I guess it was etomidate. But that was when the literature started coming out that, there's potential that even a single dose can cause obviously adrenal insufficiency and subsequent issues. So then I kind of swung very heavily in the ketamine side and actually did a pro-con debate where I was the con for etomidate at a national conference, many years ago now. I felt like I never quite got traction in the ED, but our ICU group really did convert
Hmm.
to ketamine. And then I think as, later literature has come out, kind of swung back and kind of stopped fighting the fight with it. But so I've been all over the place.
Well, I'll say that I work in our ICU, and our ICU at Vanderbilt is probably 80 or 90% etomidate as the induction medication of choice, which is what I used a lot prior to the trial. But my wife's in emergency medicine, and in Vanderbilt's ED, where she trained, the culture is a ketamine culture. So if you're a patient who came into Vanderbilt historically, if you got intubated on the first floor, it was ketamine. If you got intubated on the eighth floor, it was etomidate, and that's just always how it had been.
Okay, I'm going to jump ahead. I got to ask then, did that play a part when you're thinking of the study that essentially you were like, well, we might have semi randomized groups already just with our practice styles?
Mhm.
Well, this is the huge thing for us that we in PCCRG, our research group, are drawn to questions where it's for a single patient, two clinicians might treat that patient differently. That's like a red warning light that we don't have enough knowledge. And that's especially true if it's within our house. If Jess and I would treat a patient differently, then that's a sign that we need a trial.
And I mean, for those, unfamiliar, the SALT trial, SMART, Prepare to Device, all really high quality research done by the PCCRG. Wow, you rattled that off, by the way. That you got practice with that.
Yeah, you've given out some awards already in the show. Worst trial group acronym might be in the running. Yeah, it's now 13 years in, and we are very proud of what we've done. And the acronym's okay at best, but it does not roll off the tongue. Kevin Gibbs, one of our collaborators at Wake Forest, refers to the group as PGIRC.
Yeah, I love that.
Yeah.
Um, so I'm sure you all have a little bit of a wish list in a sense, right? Because there's probably a few of these things. So how how is it ultimately decided? Is it like democracy? Is it based on like how is that sort of? I'm always curious in high quality research groups like this how these ideas are ultimately chosen.
Yeah, I think that's a really interesting thing to think about. So, Pragmatic Critical Care Research Group, PCCRG, is these, hundreds of emergency medicine, anesthesiology, and critical care clinicians across 25 or so sites, and has done a lot of research in airway management for the last 13 years now, and fluid management, ventilator management, other things. I think the North Star is that idea of where there's variation in practice. That's what gets our spidey sense up of like, if you do it at your center one way and they do it differently here. And so I think we're just, the group is largely clinicians, not basic scientists. And I was talking all the time about, well, how would you do this? Or what do you think about this? You just saw that article. And that idea of, that actually, if there's one patient who would be treated differently by two clinicians, that's a problem. That if one of those treatments is better, that means every day in clinical practice, patients are being exposed to a treatment that might be inferior or not beneficial. And so that is our motivation. We talk about that constantly. And it is kind of interesting to see how every idea has its time and kind of comes up. So there's some of these ideas that have been on the list of things we know we do differently for years that just kind of have their moment and feel more important. And this ketamine etomidate question is definitely one of those that this is one we've wanted to get to for years. And it just kind of, the moment was right to be able to ask it.
Now, the first version of the protocol, it was published in, it looks like March of 2022. So a lot of like pharmacists or pharmacy like residents or learners are listening, and a lot of them are trying to cram research into like legitimately 7 months, right? Mainly retrospective. So to help give some of them an idea, like that's when the protocol started. But like, how long have you all actually like logistically been working on it? Because it's not like this isn't like NBA free agency where the day the protocol was released was the day you started it.
Yes, the first version of the RSI trial protocol was written in 2017, and it's 2025 that it's published. So it's 8 years. And for context, my daughter was in kindergarten then and is going into high school next year. So this has been a
Wow.
long one. But for the pharmacy residents out there and other people, not to get discouraged, this is the longest trial we've ever worked on. This had real difficulty getting funding and had regulatory concerns that were unique. So I'll give in contrast the device trial of video versus direct laryngoscopy enrolled 1,400 patients in 9 months and went from conception to completion in 18 months. So that's the size or duration that we like and so I think there is a lot of impactful research that you can do in shorter duration. I should say that our pharmacy residents and our pharmacy colleagues here are a big part of RSI. That if you look at the author list and especially the supplement, it's chock full of, Joanna Stallings and a lot of our other pharmacy collaborators here.
Yeah, we stand Joanna Stallings on this podcast. She is one of the absolute best. She was going
Yeah.
to get name dropped whether you did or myself. Yeah, absolute. Shout out Joanna,
Yeah.
just the best. Not only smartest, but just so kind, just awesome. We could go on and on.
Yeah. Well, we've got a great crew here so those who are looking for pharmacy residency or work, come to Vanderbilt. Email me.
He knows that we're literally residency recruitment is happening right now.
Right.
Look at that.
Exactly.
Okay. All right. So this idea sort of started in 2017, right? Getting actually going from idea to paper. And two previous randomized studies looked at this. One kind of before, and one got published as you're sort of going through this. So, Nicole, if you could come in, what are these two sort of highlight for us? These two big randomized trials that kind of looked into this same question prior to the RSI trial.
Sure. So the first one was published back in 2009, and this really kind of was the platform that made clinical change, I would say, just from my experience. This was a randomized control trial. This was a big study as far as the grouping. It was 12 EDs, or it was done in Europe, so there's physicians on their EMS rigs. So ED or ICU patients, and there were 65 ICUs involved with this study, and 12 EMS or ED groups. These were all critically ill patients requiring intubation, and we'll talk a little bit more, of course, about the populations later. The provider was aware of the randomization to etomidate or ketamine in that trial, but everybody else was actually blinded. And their primary outcome was the max SOFA score at 3 days. They had 230-ish patients in each group, but they found no difference in their primary outcome, which was the SOFA score, no difference in 28-day mortality. But they did show a higher adrenal insufficiency, which was as expected in the etomidate group. And that kind of, really was the platform of, maybe the study didn't have enough patients to show a mortality difference, but are there some underlying issues with using etomidate for all comers? And then the second trial was just published in 2021. This was a single center study, though, that happened in the US, and it was all critically ill patients again, requiring intubation. And this was done by an anesthesiology based airway team. This study was open label as well, etomidate versus ketamine, and there was about 400 patients in each group. They looked at survival and they found that 7 day survival was higher with ketamine, but that there was no difference with 28-day survival. So it was really, there was uncertainty with the authors too of like why that potentially would have occurred. And they did look at other surrogate endpoints too, like duration of mechanical ventilation, ICU length of stay, vasopressor use, SOFA scores, and adrenal insufficiency. And they did not find any difference between ketamine and etomidate.
And some may be listening like, wait a minute, change in SOFA score. So for those maybe less familiar, right, they were sort of investigating the interaction between etomidate or the association between etomidate and adrenal insufficiency. And so they sort of use that as a
Right.
surrogate marker because it's certainly when we think of like all of our outcomes now, that kind of stands out as a little bit different. So what are some of the why is this not a Me Too study? Because you just told me we have two randomized studies. One's multi-center, okay, one's single center, but it's US. So how does this sort of differ from some of those trials in important ways?
Yeah, I mean, I think, and obviously, Matt, this can be directed at you too, but obviously, the question to answer the mortality difference requires more patients than were available for either of these studies, and I think they were potentially fraught with type 2 error, or the mortality difference is so small that it's very difficult to find a difference. So I do feel like that, this study fills that gap as far as the sample size.
Yeah, and I'd just add that I think there are some questions where the evidence you have is kind of a Rorschach test that you can look at Keto and EVK and say, well, Keto was kind of small, but the 4% mortality difference went in favor of ketamine over etomidate, and the SOFA score, their primary outcome, the p-value is like 0.07 or something. So it's not statistically significant, but looks like there's more organ dysfunction. And EVK is positive on their primary outcome, right? It looks so those are the people maybe practicing in our ED before RSI who looked at that Rorschach and said, I'm going to use ketamine. And other people could look at the same data and say, well, both of these are negative trials at 28 days, the time point I care about. And so I think in some ways, these trials really set up this question. And the RSI trial might have been able to push this either way. So if the RSI trial found a big mortality difference with this preliminary data, that could have been viewed as consistent. But it was important, we thought, to answer that question definitively of, is there really a mortality difference here or not?
Now, Nicole, remind us because I know like a lot of the guidelines now they're doing their own meta-analyses with some of the data and things. So, remind us, do the guidelines tell us, hey, we should be preferentially using one specific agent or another from an induction perspective?
Yeah, based on the literature review that we did, and this obviously the RSI guideline used grade methodology, and the EBK study wasn't available at the time of our literature search, but we do talk about it within the article as well. But ultimately, with all of the data available, we basically say that there's no difference. We don't have a recommendation for etomidate versus another agent for induction. And we looked at, with regards to mortality, hypotension, and vasopressor use were our outcomes of interest. We do have in at the end of the rationale, that most studies did seem to have favorable hemodynamic outcomes for etomidate, and there was really, again, looking at the literature as a whole, really no reason from our perspective not to use etomidate in RSI patients or for RSI in critically ill patients.
And I'd add to that, I think the timing of when these guidelines come out is really important, right? We're going to talk about mortality. And then, as Nicole mentioned, we're going to talk about hemodynamics. And a lot of that information is contributed from EVK and then from RSI, which uh, I think actually these SCSM guidelines are very detailed in talking about things that I think many clinicians weren't really picked up on about the hemodynamic aspects of it. And that's a part that's filled in. But I would just, if it's all right, add that even we designed this trial prior to the SCCM guidelines.
Mm.
The guidelines that were available at the time we were designing the trial were the Difficult Airway Society and the Royal College of Anesthetists from 2018. Um, and those guidelines are come to a pretty different conclusion, right? So they
Mm.
say etomidate induced adrenal insufficiency is a concern, and etomidate should not be routinely used in care, and ketamine is more hemodynamically stable. So I think it's funny or interesting to see as more
Mm.
information comes, as different sets of guidelines come out, how that gets incorporated.
How nervous do you get when you're researching a question and maybe out of nowhere guidelines, the first ever get published? Did you have any like did that affect any of your like thoughts? Obviously, you're not gonna like you probably wouldn't drastically change the research, but I've always wondered like when that comes out, like are you all nervous? Is the group chat going off? Like what happens?
Yeah, oh, for sure. So these guidelines in particular were a huge topic for us that as these were coming out, we had funding and we're executing the trial and looked, very carefully at these. And we know Jared Mosier and others and talked a little bit about them. But I do think it's having now had the opportunity to sit on some guidelines committees. Um, One thing that people who have not led the trials half of it, the guidelines, I think, when they can be clear about what is known and what is required for future research, that's super helpful to us as researchers. That it is a tough position if guidelines say basically this question's answered, like our funder sees that and asks us about that. And so I think there is a delicate balance there. And having sat on guideline committees now, you want to make the guidelines helpful. You can't just say everything needs future research. But I
Right.
think not foreclosing when further evidence would be helpful, not foreclosing that possibility is something that guidelines can be good about.
So what was the study hypothesis? Going into this, what did you all think was going to happen?
So Nicole already mentioned that the mechanism that we're evaluating here primarily is that observational research for decades had raised the concern that etomidate, which blocks 11 beta hydroxylase in the adrenal gland, might and prevents the production of cortisol at least temporarily, that might increase the risk of death for critically ill patients overall, and particularly with those with sepsis. And ketamine has, as far as we know, no effect on cortisol production. And the thought had been, well, if clinicians use ketamine instead of using etomidate, might that result in lower mortality, essentially? So that the RSI trial hypothesized that using ketamine rather than etomidate would decrease the risk of in-hospital death at 28 days. That was the primary hypothesis. And then the secondary was, if there's no difference in death or other long-term outcomes, then we as clinicians often make this decision around hemodynamic instability and safety during the procedure. So our secondary hypothesis was around that for decades, ketamine had historically been considered the most hemodynamically stable induction medicine because it increases plasma catecholamines. And we probably will talk more about hemodynamics and physiology later, but the secondary hypothesis was using ketamine rather than etomidate would decrease the incidence of cardiovascular collapse, hypotension, vasopressors, cardiac arrest during the intubation procedure.
Well, for those who somehow haven't heard anything about this study, what we're going to do, I'm going to review a little bit of the study methodology, get Nicole and Matt a little bit of a breather, but then they'll add in anything that they think is important or want to reemphasize, and we'll kind of go from there. So the RSI trial, ketamine or etomidate for tracheal intubation of critically ill adults. So pragmatic US multi-center unblinded randomized parallel group trial. So 6 US hospitals, 6 EDs, and 8 ICUs. They're listed in the supplementary appendix if you're curious. Enrolled adult critically ill patients undergoing tracheal intubation with the use of a sedative to induce anesthesia, right? As broad as we can be. They're undergoing RSI essentially. Key exclusion criteria: pregnancy, prisoners, trauma patients. We're going to put a pin in that. We'll definitely come back to that. Unable to enroll, clinicians determined that one agent was necessary or contraindicated. So patients were randomized 1-to-1 to receive ketamine or etomidate from April 2022 through August 2025. So the clinicians, they utilized a dosing chart that sort of delineated full dose, intermediate dose, or reduced dose of either sedative. So if you're curious, that is in page 15 and 16 of the supplementary appendix. If you're watching on YouTube, shout out to you, but you're seeing the chart in real time. So you can see it's got reduced, intermediate, and full. But a couple tips here for the pharmacists listening: appears they used actual body weight, and the dosing chart was a guide, not necessarily a strict protocol. So back to the study itself. Primary outcome: 28-day in-hospital mortality. That composite secondary outcome of cardiovascular collapse during intubation, defined as either systolic blood pressure less than 65 millimeters of mercury, new or increased dose of vasopressors, or new onset cardiac arrest, basically from induction to 2 minutes post-intubation. So in that immediate period. So exploratory outcomes: induced ICU included ICU-free, vasopressor-free, and ventilator-free days at 28. Few post hoc outcomes, right? Incidence of ventricular arrhythmias or bradycardia, essentially comparing hemodynamic safety, and calculated that just over 2,300 patients would need to be enrolled to meet power. Shout out to you all. Ultimately, 2,365 patients were enrolled. So from a methodology perspective, feel free, anything you want to add or sort of re-emphasize from that perspective.
No, I think that, I mean, that's a very clear summary. I would say that I think the this trial with 2,365 patients is, I think, the largest intubation trial ever done. And it's intended to rule out the size of effects that we're seeing in some of the prior observational studies and hinted at in the prior trials. You know, it's 7% mortality difference in EVK at 7 days, and it's 4% difference in Lancet. So that's what 2,500 patients gets you. This trial can't rule out, it isn't powered to rule out 1% differences or these tiny differences. So that's just in thinking about who's in the trial and the sample size. That's one thing that's worth noting, is this is intended to be able to make sure that we're not missing a signal that's about what was seen in the observational data, but it's not focused on infinitesimally small differences, even though those might be important for a really common intervention like this.
Other than controlling the induction agent used, right? They got randomized to either etomidate or ketamine. Were there any other aspects of RSI or even post-intubation, right, ventilator management that were dictated by the study itself?
No, the trial controlled the induction medication, ketamine versus etomidate, and provided clinicians, as you mentioned, with that information on dosing that's in the FDA label and up to date in Medline. But clinicians determined everything else. So clinicians chose whether the patient received a neuromuscular blocker, and 99% of patients did, and whether they got steroids after intubation, which was similar in the two groups. But basically, all aspects of practice were guided. We say by clinicians, but in most of these settings, it's by institutional protocols, ventilator protocols, sedation protocols, et cetera.
So we mentioned trauma patients were excluded, right? And I mentioned we're going to bring up some of the questions or discussion points. I even kind of pulled some of my intensivists that I work with to get there, and they, discussing excluding trauma patients as a limitation. Whereas, like, instantly, my thought before I even heard that, I actually thought that was a strength when we think of like phenotypes and patient populations. But what was the discussion or reasoning behind that? Because that feels like one of the big 3 points, if as people are kind of talking through the study that people love to list.
Yeah, it's a great question. We talked, as you can imagine, talked about this. It's really the only exclusion criteria besides things were happening too fast so trauma is really the main exclusion criteria, and it's patients who are presenting to the ED with a primary diagnosis of trauma. So there are some trauma patients in the trial, but in 2016, 2017, when we were designing this, there were two questions that we were led to that. One of which was there was this persistent idea that ketamine might increase intracranial pressure in the context of traumatic brain injury. I don't think that's true. I think we have some data, at least physiologic data, to show that it probably doesn't increase intracranial pressure. But in terms of asking clinicians across this broad network to enroll all of their trauma patients, that was item one. Would that be seen as acceptable? And I say that knowing that every trauma patient at Vanderbilt is intubated with ketamine for the last 15 years. So we're a setting in which we view that as acceptable, but that's not necessarily universal. And the second was that in some of the preliminary data, like the Keto trial, the point estimates for all of the patients favored ketamine, except in trauma, where it kind of seemed to go the other way. And so we wondered, are there physiologic reasons why adrenal insufficiency is a big deal in sepsis, but in trauma, maybe that different, the illness is different, and hemorrhagic shock and other things are predominant. And so our decision at the time was these might be best evaluated separately. So our hope was to do an RSI trauma trial and then try and do an RSI trauma trial, which we've applied for funding for and have not yet received. And so I think there's a separate question, which is, should we try and answer that separately? I think that's yes. But now that we have the RSI data, it kind of cuts the legs out from under that a little bit, which is the whole point of this was that adrenal insufficiency might be a problem that increases mortality. And we're going to get to the results of the RSI trial, but it doesn't seem to, even in patients with septic shock and patients most at risk of adrenal insufficiency, that undermines the strength of our idea that this might do that in trauma, that I'm not really sure why it would matter in trauma if it didn't in sepsis and shock. So I'd be interested in your perspectives or the internet's perspective, but that's kind of the rationale for it.
Yeah, the internet seems to think they want this to be like the Crash 2 trial where literally anybody getting it at all comes in, which to be honest, as somebody who I feel like I read a lot of studies or things like that, this feels like if you would have done that, the exact same people would have been like, well, how can we apply? These are different populations. You know what I mean? It feels like that. In my mind, like that's probably what would have happened.
Of course. Yeah, yeah. Those are the only two options. Yeah.
Now, you mentioned this, the 10th exclusion criteria, right? It's stated as the immediate need for tracheal intubation, right? Precludes safe performance of study procedures, right? Essentially, these patients were too sick to enroll. They needed immediate action right away. So, what was that time frame in terms of how too quick to enroll? Because obviously RSI is that it's rapid, right? So all of this is happening in an
Yeah.
emergency. So what was that time frame, and how was that even chosen?
So, as you mentioned, about 10% of patients were excluded because the intubation was too urgent to perform the study procedures. And what those study procedures are very simple. So, in the participating EDs, we have manila envelopes in a file for the study, and they're with the airway equipment. And as someone runs to grab the airway equipment, the envelope comes with it. And what clinicians have to do during that emergency procedure is review those eligibility criteria on the outside of the envelope. And you saw they're very simple. And if the patient's eligible, open the envelope and pull out the randomized trial group assignment, etomidate or ketamine. So that takes about 30 seconds, and that can be done, as we showed, 90% of the time, or not, a little bit more than that. And so the vast majority of intubations in the ED and ICU are being included here because you could do that during pre-oxygenation. Um, and that includes, you can see 5% of the patients in the trial had a cardiac arrest before intubation. So these are even in situations where the patients are coming in the ED, dropped off in cardiac arrest, some proportion of those are being enrolled. So this is a very sick, urgent group of patients. But we essentially allowed the clinicians the discretion to say, in rare instances, hey, I can't do it in this situation. I had single clinician coverage and there's a patient in cardiac arrest. I can't take those 30 seconds to open that envelope. So that happens, and it's a proportion of the time, but I think it's pretty small proportion of the time. And we're still enrolling a group of patients who are extraordinarily sick during an emergency procedure.
So I'm used to seeing a laundry list of secondary outcomes, but I opened this trial PDF, and boy, to my enjoyment, there was one, a lot of exploratory outcomes. So what led to this unique change, and let's try to get a PSA for everybody listening to maybe possibly follow suit and make and help us out here. But this was awesome, by the way. This was a great touch.
Well, I really appreciate it. And this is something we've kind of moved towards as a research group over time that, as you all know, the more outcomes you look at, the more likely that one of those will differ between the trial groups just by chance. And for several years now in our trials, we have specified one primary outcome and one secondary outcome and described everything else as exploratory with the idea of, well, you have to describe the population and what happened, but we want to make really clear, we want to pre-specify in advance, this is what we're interested in. This is what we hypothesize will differ between the groups. This is where we're spending our statistical power. And so if you see a difference in those outcomes, you know, this isn't one of 25 different things that they're just elevating because it happened to be different. We put that money down in advance. And so for the RSI trial, mortality, primary, hemodynamics, or cardiovascular collapse, secondary, period. That's what we were interested in.
Okay, last methodologic question. It feels like one of the probably bigger discussion points kind of across the board from podcasts, websites, editorials. Um, the power calculation, specifically looking for that 5% difference in the primary outcome. When you sort of dig into the text, and I mean these protocol and supplementary appendix, everybody should be required reading to especially go through some of that. You know, it's sort of mentioned there's a Lancet respiratory medicine article sort of using Bayesian models to predict things. So if you can try to summarize, because I'm sure it could get very in the weeds to how this was ultimately chosen, and explain that it wasn't just like out of a hat. Well, coin flip, it's going to head five, tails 10, right? But like, so how, like, what kind of went through the thinking here?
Yeah, so this is one of the most important parts of designing clinical trials. And I think there are four factors that go into this. The first three are the clinical meaning of a given detectable difference. The second is the plausibility of it. And the third is the feasibility. And then we'll talk about what's meaningful to patients and clinicians. So that clinically meaningful difference, some people talk about the minimum clinically important difference, or MCID, as a guide. Some people talk about that as if it's a fixed property of the outcome, that mortality might have some difference that's meaningful, that's generalizable to all studies. But I think that doesn't have face validity. That is to say, if you've got $1 million drug that's going to have a huge cost and be hard to implement, well, you know, that might require a 10% difference or 7% difference or something to be meaningful. And if you were talking about saline versus balanced crystalloids, which are free and used everywhere, well, it might be that the difference in mortality that would take to switch practices is almost nothing, 1% or 0.5%, right? So I don't believe in MCID as a property of an outcome, right? So I think it's important to ask the question of what's meaningful to clinicians, what's meaningful to patients, and we can talk about how we did that here. But I think that there may be a little bit of an over focus in the trials community on this idea of MCID. That's often MCID, or minimal clinically important difference, is often contrasted with what's plausible based on the preliminary data. So we look back through the observational research, which is finding a 4 or 5% mortality difference. The EVK trial, which was 7% at 7 days and 3 or 4% at 28 days. Ketamine trial, which was 6% in the non-trauma patients. So we're trying to pick a number that situates within what the preliminary data suggest might be there, so that at a minimum, we can confidently say, hey, that difference that you thought was there is not there. We can't rule out a 1% difference, but we're certain that the difference that had everybody talking or everybody worried about this doesn't exist. And then the third consideration is feasibility. Basically, if those numbers add up to something that you can't execute, that's a real problem. It's always better to have some data than no data. So I would definitely rather have a 2,500 patient trial and rule out a 5% difference or 3% difference than none. And I wouldn't not do the trial just because we thought, oh, even a 2% difference would be important. It's still better to have the trial. And then just as the last piece on that, this research was funded both by the NHLBI and the Patient-Centered Outcomes Research Institute. And through that PCORI funding, we have a huge amount of patient and family and community member engagement into these sorts of decisions. And you see it subtle in there, but part of that engagement was walking down the difference that we were able to detect, which means walking up the sample size. So because of the input from survivors of critical illness and their families, that sample size increased from 1,900 in the initial design to that 2,365 patient. Those are the factors that went into that.
That's so cool. Yeah, I think people have to understand how much funding, feasibility, all of these different things matter. And like, yeah, I'm sure you had a laundry list of things if you had $100 million and an endless thing and be able to using as many research assistants as you could. But it's kind of like prescribing a medicine that's perfect, but a patient can't pay for it. It's like it does that kind of related to
Well,
that.
I think this is a huge deal that I think it may not be something that everyone's familiar with, that the costs of some of these trials, especially when you talk about medicines, get to be really incredible. So it's publicly available, the funding for this trial, and the total funding for this trial was about $8 million over 8 years. And the honest answer is we could do this trial for a huge amount less than that were there different regulations in place, but the regulations in the US for drugs treat comparing the two most common drugs that are generic and have been used since before I was born for this purpose, no differently than they treat a new drug that a pharmaceutical company is going to make $1 billion off of. So the regulatory burdens are associated with this sort of research cause that cost. And that's a problem, both because it's our taxpayer money paying for it, but also because it limits the questions you can ask, right? That if it costs $8 million to compare to the two drugs that patients are getting arbitrarily, you can't ask ketamine etomidate and ketamine propofol and etomidate benzos and sucks rock. The result of these regulatory barriers, which in some ways are intended, I think, to protect patients, is that patients are being arbitrarily exposed to these treatments without evidence in clinical care. So we see that as a huge ethical problem and a motivator for our work.
Well, and until, you're one of, a couple research groups that's really leading the way and getting some US critical care research, but until that point, right? That's why, most of our data, a lot of it was European, right? And so being able, we'll talk about that a little bit, but that being able to compare across patient populations and things and being able to have US based studies, I that also is really important, I think.
There's no question that that's true, that this is a place where the regulatory differences between countries has meant that a lot of the critical care research that we base our practice on in the US has been from outside of the US historically.
All right. So the reason why probably a lot of listeners are still here, let's get into these results, right? So the treatment arms, they were evenly balanced. 1,176 patients received ketamine, 1,189 patients received etomidate. And if you're watching on YouTube, number one, you should be. You could see this. We're going to table one. In the PDF. So about 56% of patients in the ED, about 44% in the ICU, about 45% with sepsis or septic shock. Median GCS was 11. About a fifth of them receiving vasopressors at baseline, and about another fifth, they got an increased dose at intubation, right? So, potentially seeing a downward trend and bringing that up. And notable, about 70% of patients received rocuronium as their paralytic. Median doses, about 1.6 mg per kg of ketamine and 0.28 mg per kg of etomidate. And in that primary outcome, 28-day mortality, no statistically significant difference. You'll see places, we'll get into this, the numeric difference of that 1%, 28.1% of ketamine versus 29% of etomidate in the 28-day in-hospital mortality. But when we think of that secondary outcome, ketamine significantly increased the risk of that composite of cardiovascular collapse, 22% versus 17%, and specifically driven by a new or increased rate of vasopressor. Also notable that this was in the higher in the subgroups of patients with sepsis or septic shock and elevated Apache 2 scores. And then from a exploratory outcome perspective, ketamine had a significantly higher rate of systolic blood pressure less than 80, as well as a systolic blood pressure of greater than 30 compared to etomidate. And these took place, right, despite getting what was described as an intermediate dose. So a lot to unpack there. Anything you all want to highlight, emphasize? There's definitely I wasn't able to get through all 100 plus pages. So if there's anything, feel free to hop in.
No, I think you summarized that really nicely. That we talked about trying to specify the things that we're really going to focus on, and one is mortality. And so that primary outcome of 28-day in-hospital mortality was nearly identical in the groups. We did also report, we're following these patients to a year, and that follow-up's ongoing, but that meant that we also had all location mortality, so called patients and their families at home, and that was I think 32.2% in the ketamine group, 32.4% in the etomidate group, and the difference between those is 0.0%. So I think in terms of flatly negative primary outcomes, this is as close as we get. That if you just flipped a coin that many times, you'd have more variation than we see in that outcome. So as somebody who has used etomidate and has been in an environment where people have told me that I found that extremely reassuring. And then that secondary outcome, the only other thing we were looking at was this question of what was the effect of ketamine on blood pressure during the procedure, um, which is important for clinicians. This is a high stress moment, and oftentimes, we can talk about what it means to have a patient become hypotensive or need vasopressors during intubation. But what we saw there was exactly as you described, which was that outcome is three things: lower blood pressure, more, vasopressor administration, and cardiac arrest. And no matter how you looked at blood pressure, it was lower with ketamine than it was with etomidate. And we can talk about why that was a little bit surprising, I think, for maybe people who weren't as deeply in this literature. So whatever
Now,
kind
what did you think? What did you think when these results came out, right? Because, like you said, these kind of contradict the hypothesis, right, in a lot of people's minds. So, what was the feeling or the sentiment when you got this? Because obviously, numbers don't lie, and you all are a research-based group. So I don't foresee anecdotal sorts of things. But how was that discussion? 'Cause it's probably strange, right? Completely the opposite of what you were expecting.
Yes, so I think that in some ways for most people was the most surprising finding of the trial. I think you have people like Nicole who've been deep in the weeds in this literature for 5 years or 10 years, and I think they knew this was coming, right? That, the observational data from the NEAR registry, the EVK trial, which measured the same outcome in the same way and found that ketamine increased the risk of low blood pressure and vaso. So I think for people who are really in this literature, this would be the expected finding. But I think for most people, including us when we were designing the trial, you can see our hypothesis, we had history telling and culture telling us, oh, ketamine's great for blood pressure. Use it when a patient's at risk of hypotension. It increases catecholamine levels, and that overcomes the negative inotropy and vasodilation. And I think for a lot of people, we actually surveyed internationally and within our network when we knew the results, but no one else did. And probably it was 90% of people said that ketamine would be at least hemodynamically stable or more hemodynamically stable. So the vast majority of clinicians have been using ketamine with the belief that it's either more hemodynamically stable or at least as good. And so I think, except to very expert people in the weeds like Nicole, that was maybe the most surprising finding of these results.
Nicole, did any of these findings like surprise you as you kind of went through, or is Matt kind of did he hit the nail on the head?
I think you hit the nail on the head. And it's interesting too, because a lot of it does seem that the clinicians though did um, choose to dose adjust the ketamine. So you do wonder if, obviously there's some attention to the curiosity about catecholamine depletion and the effects on ketamine. We obviously saw that differently compared to the etomidate dose. So
One of the things that is really in the weeds in this consort diagram that I found interesting in retrospect is there are very few patients who are excluded. But among those who are excluded, one of the rare reasons for exclusion is, well, this is a patient actually who we know needs ketamine, not etomidate. And one of those reasons was the patient's too hypotensive to safely get etomidate, right? And so that was like one of the main reasons one of the exclusions. So I think it spoke to that idea that a lot of people thought that ketamine was the more hemodynamically stable agent.
Yeah.
We got to jump ahead since you mentioned it, and we need to give the most major shout out to you and your research colleagues because the two things that stood out to me, single digit patients were excluded
Mm.
after, and over 99% in each arm received the treatment that they were randomized to, which is like tremendous when you're thinking, like when you look at the supplementary appendix, these are some of the busiest EDs and the sickest ICUs in the country, and you're doing all these things. So that is amazing, amazing work to you all, and clearly like the culture that your group has, because that's, you got to give a shout out for the, like, you might look at it and it doesn't seem impressive, but that was the by far the most impressive thing to me.
So you're describing what we jokingly call the clinical trialist's favorite slide, which is that everybody's interested in the results, but the results are just facts. We can't change those. The piece that we can change is how well did we deliver the intervention. And I think this is just a testament to the site investigators and the site coordinators and the clinicians buy into this, that this is, these 14 hundreds of clinicians at 14 EDs and ICUs across the country and are just an incredible group who really believe this work is important. And that idea, I mean, this is occurring during an emergency procedure in the middle of the night, and 99.6% of patients get the assigned drug.
Yeah, that's the
Yeah.
thing. When you picture this, it's not 10 in the morning when this is happening. It's
No.
1 in the morning when this is happening.
Yeah. And so that's we're so thankful to have this network and these collaborators. And that's what lets us get so much value out of this. That if it's, 70% in one group and 60% in the other group, you can't learn nearly as much. But we these are the effects of ketamine and etomidate simply. And we know that because of the teamwork of those researchers and clinicians at those sites.
And so, for some of the listeners, right, one of the pharmacist authors, Kristen Sherlin, she's going to come on for a little bonus episode, talk through, right, what's it like being in the room, trying to get EM and crit care providers to care about these sorts of things. We're going to ask this question here too, but we'll get a little peek behind the curtain there. So definitely stay tuned. Now, I want to come back to this secondary outcome, right? It's kind of drilled when you get statistics learned. Primary is what you take away. Every, right, the secondary and things hypothesis generating. So explain why your trial design was created in a way to sort of disprove that sort of idea that any secondary outcome is exclusively hypothesis generating.
Yeah, that's a great question. And part of the basic rationale is when you're designing a trial, um, you can you're worried about cheating to make your your intervention look good, right? So if you have a lot of different outcomes and you can win on them, then your antenna go up that, hey, there's a chance that these are just chance findings. So the first thing that I point out is in this instance, our winning, showing that ketamine is better, it would be an improvement in mortality for the primary outcome. But things that are safety issues, that actually
Mhm.
framework doesn't apply to, right? So we're not winning if ketamine shows a higher rate of hemodynamic collapse or other problems. And that's why oftentimes you'll see in trials a p-value for the primary outcome that you're trying to win on, but you'll also see p-values for safety outcomes because those are actually places that you lose on. So it doesn't have the issue of multiplicity necessarily that you do if you're all in the direction favoring the intervention. That's the first piece. The second piece is with secondary outcomes, there's often a lot of value in a trial beyond the primary outcome. I think there's actually a New England Journal editorial series that asks that question about what to do when the primary outcome is negative. And one of the most important things is to look for is consistency, right? So I think if you look at RSI, one of the things that reassures you, hey, this is real, this is not a chance finding, is there's no, we present hemodynamics and vasopressor receipt in every imaginable fashion. And in every one of them, ketamine decreases blood pressure and increases the requirement for vasopressors. So I think that consistency is, if somebody's looking at this and looking at the secondary outcome, knowing that there are only two pre-specified outcomes, primary and secondary, knowing that you weren't at risk of having multiple chances to win where multiplicity is the biggest issue, and knowing that the secondary outcome is consistent in with all the exploratory outcomes, I think gives you a confidence here that this is probably a real finding and might inform your practice.
Nicole, I'm curious your thoughts on the theory of, do you think it's more negative inotropy or vasodilatation, or do we know sort of like why some of this hypotension happens with ketamine?
Yeah, I don't think we know totally why it happens. But I do think it's, it's you have the negative inotropy that occurs, and normally you have enough endogenous catecholamines to overcome that. But in these patients that, potentially have septic shock or some sort of, extreme surge on the system, that there's just not that ability to overcome. So, I guess I don't know if that doesn't answer. Is it the inotropy or is it the the vasodilatation? It's the combination of the two, I think.
I'm glad you asked Nicole because I don't know either.
So another thing that I sort of saw, right? The big thing is this significant secondary outcome, right? So I always like to take sort of the other side. So, okay, one group requires more vasopressors. Do we care if the mortality wasn't different? Or are the details behind one group needing more vasopressors a little more complex than like, well, 1 out of 5 patients we need to make sure we have levo ready for compared to the other? Because I feel like when you look at differences, feels a little more nuanced than that.
Well, we always joke that the main responses to a clinical trial, your options are, I already knew that, or so what, you know, and so you're talking about so what. I think that's a good question. So, I mean, to people who are there taking care of critically ill patients as they get intubated, that is a question: is, does hypotension during the procedure matter? And I think the argument that it does would be a couple things. One of which is that there are only two things probably that affect the risk of cardiac arrest during intubation. One is low oxygen level, and one of which is low blood pressure. And those are the only two things we can modify probably to prevent people from arresting, or at least the two most important things. And there's a host of observational literature suggesting that preventing people from having low blood pressure prevents them from having cardiac arrest during intubation. And patients who have cardiac arrest during intubation do not do well. This is not a surprise to anyone. 25% of them never regain a ROSC, so that's death. And then of those who do get ROSC and get a pulse back, something like 80 or 90% of them die in the hospital. So avoiding a patient having a cardiac arrest during intubation is a big deal. And preventing hypoxemia and preventing hypotension seem like our two ways of doing that. And this is something that the community seems to value enough that preventing hypotension during intubation, this same outcome, is the primary outcome for prior trials. So the PREPARE trial, the PREPARE 2 trial, all we were trying to do in those trials was see, does the intervention prevent hypotension and vasopressors or cardiac arrest during intubation? So at least in those trials, that was the main focus, and it meant something then. Talking about the other low blood pressure here being different between groups, we're talking about very low blood pressure. These are systolic blood pressures less than 80 that using etomidate rather than ketamine is preventing, right? So it is a difference in vasopressors, but it's largely a difference in vasopressors being given to a patient who's already pretty hypotensive, that there's systolic blood pressures in the 70s or the 60s. So I think it's a big difference that is in blood pressure as well as vasopressor administration. And I think it's important to remember all of these settings are EDs and ICUs at pretty high performing academic hospitals that have a lot of people in the room. And so managing low blood pressure, that can be rescued better here and might not translate into more downstream outcomes, cardiac arrest, other problems than it might if you're alone in an ambulance or you're a flight medic and are having to try and manage patients through these complications in a setting where there's not 15 other people in the room controlling the vasopressors, if that makes sense.
I thought it was notable, right? Figure S8, it not only shows sort of the pre-specified, but also sort of that post hoc. And I think it's notable that the numbers kind of stay the same from the 80 to 60, like systolic blood pressure less than 80 to 65, right? So like a decent amount of these patients, is not like their systolic was 79, right? It's probably more like 60 or 59. And that's systolic blood pressure, right? Not MAP. We need to remind. So like,
Right.
yeah. And the the trend and all those things and getting that hypotensive, right? That's something we probably want to avoid, like you had mentioned, right? And especially we don't know, depending on disease outcomes, right? All those blood pressure variabilities. So yeah, I like that you did that because I do think it's more important, but I think some people just see the mortality, they see no difference, they see this, they're like, well, I don't know. But I think some of the nuances with it, I think are important to dive into.
Well, let me turn that back to you and Nicole. When you're working clinically or when you're, taking, sitting there helping prepare the medicines and the vasopressors and everything in this instance, is this is one of the goals you have going into this procedure to choose medicines that are going to prevent low blood pressure, vasopressors, or where does this sit in the relative priority of the things you're thinking about as a patient's about to get intubated?
Yeah, I mean, I think it's obviously high priority to think about, but if we can prevent having to treat a potential negative outcome from the procedure itself, that's the primary goal. Um, and then it obviously adds in the question of do you start vasopressors before, how much fluid resuscitation, all of that, and it creates more convolution, I think, having to prepare for that. So the goal, would be to try to prevent hypotension from occurring, of course.
Very safe and effective pharmacotherapy, right? So it's like that
Yeah,
number two, right? I completely agree. And it's one of those like, okay, we have two agents. Okay, maybe we're saying that they're similar in efficacy, but one is worse in safety. To me, that feels like an easy choice outside of
right.
patient-specific decisions that have to get made.
Yeah, and just, how we were talking before about, this being a secondary outcome, it's an important secondary safety outcome. And we of course have to look at the positivity and the efficacy of any drugs, but also the negative effects. And, I agree with Nick and with you, Matt, that this is, a significant outcome that the RSI trial found.
We mentioned we extrapolate plenty of data from the European research and health systems there. Um, do you see any findings just on the surface, right, of sort of applying these internationally? Are there any massive differences maybe to how we perform RSI or things like that to where you would maybe put pause to some of our maybe European or Asian colleagues of sort of applying this info?
That's a great question that's particularly relevant for this trial in a way, even more so than it usually is. So those, ketamine and etomidate are these cheap generic medicines, but the concerns about adrenal insufficiency with etomidate have been so significant in other parts of the world that etomidate's been pulled from the market, right? So of the G20 countries, of those 20 countries, there are six which have not approved or have pulled etomidate for use. So if you practice in Australia, you cannot give etomidate if you want to. If you practice in Japan, you mentioned Asia, you cannot give etomidate. I think it's not maybe in the market in Italy. So this trial, the implications of it are very different. So in those settings, if you're using ketamine and thinking it's a hemodynamically stable agent, at least in the short term, the response to this can't be, well, I'll give etomidate instead, because the concerns about adrenal insufficiency, which I think this trial probably argues were overstated or maybe non-existent, mean the drug's not available to you for use right now. So I think in some other countries, people may look at this data and say, is this a drug that actually we do want to have available for use in critically ill patients and lead to reintroducing it to the market? But for places where that's context, they don't have access to it currently. I think that you are kind of forced to extrapolate to this to say, well, we might have ketamine and propofol and benzodiazepines and maybe phenobarb. What do we use now that we know that ketamine may not be as hemodynamically stable as it used to be? And I think it means we need more comparative data. So there haven't been big trials of ketamine versus propofol, for example. And that's the choice that a lot of people are making. And there are trials from the Brazilian group on this question now that should be available soon. I think this has been the question has been kind of under the surface for decades. 13 million patients undergo this procedure every year, and all of them almost get these drugs, and yet we really haven't had much data to tell us which are best. I hope this, in settings where etomidate's not available, especially leads to this outpouring of comparative research of, well, what are the actual effects of these drugs? They're not as benign as we thought they were.
All right, so Matt, I want to come back to something that you had mentioned. You said essentially that the way your hospital was set up, right? Etomidate was sort of the induction agent used in the ICUs, and ketamine was the agent used in the EDs. So you get this data. So I'm just picturing you have the ED nurse that's been there 15 years, right? Let's just say Dr. John is going to, he always likes ketamine and sucks. So she brings it in, gets it ready, but he asks for etomidate. So did you have those sorts of things where like things were people sort of got an idea of what was happening, not from anyone saying anything, but just from subtle changes in practice?
Yeah, that's a great question. I'll say for our ICU, we haven't had much practice change based on this. RED, Stephanie DeMasi is our site PI down there, and they I think, were great contributors to the trial. And when you've been leading this research, it's much easier to help implement the results. So RED for medical innovations has seen a real sea change. Your question was about between the period when the trial is finished and we know the results and when it's public. And for many trials, that's years. So for prior trials like video laryngoscopy, pre-oxygenation with non-invasive ventilation, that definitely happened in our ICU that we said, these results will be available soon, but just put non-invasive on today, this trial, the timeline between when we knew the results and when everyone knew the results was incredibly short. So this trial finished August 10th enrollment. The 28-day outcome was available September 10th or whatever. And this trial was accepted for publication 40 days later or something like that. Not submitted, was accepted, and then was presented December 9th. So that timeline, for a trial that took 8 years to complete, the time from last patient enrolled to this being public for everyone was the shortest we've ever had.
Like hyper speed. I don't think
Yeah.
people
Yeah.
understand how 40 days is nuts to have all of this data.
Yeah. And have gotten
It
through
was,
the, yeah.
or I was just going to say, when I was reading the trial and I looked at the inclusion dates and that the trial ended August 10th, 2025, I was like, 2025, this was just published. Like it's incredible that it was able to get turned around and published so quickly.
Well, we felt hugely under the gun when there's something as common as this is, and you have information to make sure everybody knows it and has a chance to use it. But we have to shout out Brant Imhoff is the statistician who that largely fell on, and our statistical team, Brant and Lee Wang and Matt Shotwell and everyone, in addition to everybody at all the sites, that it is an incredible amount of data to get cleaned and get ready on such a short timeline.
So I have to ask, right? Describe what it's like seeing your name on a New England Journal of Medicine article. Does it ever feel not awesome? That has to be one of the coolest things to see is your name like on that byline, essentially.
We get a lot of joy out of these trial results publications. And part of that is that publishing in the New England Journal is great because the New England Journal is great, but it's really great because it means people read it and it informs people's practice. And then it's in the next SCCM guidelines. And we've taken to watching UpToDate and just checking it every day. And so a joy for us is when we really know we've done it when UpToDate changes. So for this trial, I don't know if they had a heads up in advance, but UpToDate updated their guidelines from the RSI trial within 24 hours. It was just like, so that's the guideline that I go to, and that piece of it of, there's a lot of research that people do that they work very hard on, that we work very hard on, and you publish it and it's kind of crickets and it goes off into the distance and you feel like you haven't made a difference. So we really value these projects where we feel like we had this question that as clinicians we were frustrated by the variability in practice and we didn't have the evidence we needed, and everything can work through the pipeline and publish the trial in a place that it will inform practice and inform guidelines. And yes, that's a great thing to be able to be a part of.
That would have probably been a hard thing to keep under wraps for like 6 months. And I would think that like when you're going to propose to somebody, like the wedding ring is like, you turns you into Gollum. I feel like having this data would be the same idea, right? Trying to have that. It's like, we're going to use etomidate. Just don't tell anybody.
Yeah. When really you're telling everyone.
um, so, one of my favorite phrases, right? The devil's in the details. And this supplementary appendix, 94 pages of details. Either of you have favorite things you want to highlight, like a favorite table, figure, etc. I have a couple things we'll shout out of Nick's favorites of it, but I wanted to give you all the opportunity first so I didn't steal them.
I'll answer that first, which is that I recommend that listeners read all 93 pages of the supplement in detail, that it's all favorite. Um, no, the intention is basically we're trying to generate this information and make all of it available. And so if you have a question about the trial, generally the answer is probably in the supplement, that there's just so much there. My favorite is figure S7. So that's very specific. But that's something different. And I'd talk about it if it's all right for 1 minute, that these trials forever, all randomized trials forever, have provided the strongest evidence on the causal effects of things, but they've done it on average, right? So they've done it as if every patient responds the same way to the same treatment. So trials will always say, well, what's the effect of ketamine on mortality? Well, there's no effect on average, but that's treating a 96-year-old woman with sepsis and AKI as if she's going to have the exact same response as a 21-year-old with, who's coming in with bad pancreatitis or whatever. And we know as clinicians that patients in many instances probably respond differently to the same treatments, and that we've often individualized those in care, but that's not evidence-based. So in some ways, the dream for us is evidence-based personalized medicine. So it's clinical trials that tell us not the treatment effect on average, but for an individual patient based on their 25 different characteristics, what's the right treatment for them? And this is the first trial I know of to present that as part of the main results. So this is that figure, and this is Matt Sherpeck at Wisconsin and Alex Spicer and their team of data scientists are responsible for this. And they, during the conduct of the trial, we worked with them and basically transferred to them so that they could be developing a model that would predict a machine learning model using the first 1,700 patients that would say, hey, I don't want the effect on average. Here's the patient who has, this is their age and their sex and their sepsis and their severity of illness and everything. I think this patient, this model predicts would benefit from ketamine. And this other patient, I think, would benefit from etomidate. So individualized treatment effects. And then after we enrolled the remaining 600 patients in the trial, only after that model was locked and shared with an honest broker, we gave them that data and said, was that model right? And did the effect of ketamine versus etomidate on mortality differ for different patients? Because in a trial that's negative, it's always everybody's first question is, oh, yeah, sure, it was negative overall. What about sepsis? Or what about my special population? And RSI has this special piece to it that no other trials, most other trials don't have, which is we can say not only is there no effect on mortality overall between ketamine and etomidate, there's no effect that we can find even for individual patients when we take this very sophisticated approach to trying to find any patients for whom this matters. So I think that's very methodologically wonky. But the reason I love it so much is I hope this is where clinical trials go, that in the long run, the result of a trial is not a thumbs up or thumbs down decision, but it's individualized for every patient.
I'm sorry. I just wanted to highlight figure S9 too. I thought was a really good one from the supplement. Just obviously going through all these different subgroups with patients with sepsis, adrenal insufficiency, neurologic conditions, severity of illness, and I thought this was a good depiction of the
Yeah,
results.
this points out an oversight on my part. We talked all about the hemodynamics, but we didn't point out the fact that actually ketamine caused more cardiovascular collapse in the exact patients we thought that it would help, right? That, compared to the average patient, patients with sepsis, it was like a 10% difference in cardiovascular collapse in
Mhm.
favor of etomidate. That's the group I might have been most likely to use ketamine in, or patients with shock or patients with high severity of illness. So this is a really important one that I'd forgotten to even mention. But all the patients we thought ketamine was helping are the patients where it looks worst.
Okay, a couple more. Those were reasons. Number one, everyone should do the supplementary appendix. Those were real reasons why you should definitely look at. We're gonna have some fun here. So my favorite reason for why one specific induction agent was needed, patient preference.
Um,
I, you're getting intubated a lot when you see someone pulling up ketamine. You're like, wait, no, that doesn't work for me. Um, any of the residents or attendings that I work with, I always joke, I'm like, if you let the medical student intubate me, I will haunt you for the rest of your life. I want to highlight that
Right.
for those involved, they all had greater than 50 previous intubations, which I thought was a key note when you look like 80 to 90% of them are either residents or fellows who were doing a lot of that. And important to note, right? The whole reason of why we do RSI is to try to have successful first pass rate, and 85% was noted in this. So obviously, kudos to all the physicians who were doing the intubating. Fantastic title and trial acronym. So Matt, who do we give credit for? I'm preemptively giving it to you. You can choose to give that away or not.
In this rare case, that's true. That this is one of the things that for years has been part of my joy, although others in our research group have gotten good enough at it that I'm sometimes losing the battle. But RSI is mine, and I love that aspect uh, of thinking of a new trial.
So is do the, a lot of us have seen the supplementary appendix that shows like people voting on like decisions to be made or things. Do you all follow that same strict methodology to determine how the acronym, or is it just one of those like it when you hear it, everyone just kind of gets it?
When there's a winner, there's a winner. That one does not. We are lucky to have a lot of input and executive committee and everything, but it's always obvious what the trial should be named.
Yeah. Randomized trial sedation choice for intubation. I'm assuming that means randomized sedative intubation RSI. So cool.
RSI.
Yes. And then of course, research team, shout out you all. That's awesome. All right. Couple like listener questions. So we polled the audience and I think we got some really good ones here, right? So a lot of the listeners may be critical care based. So a lot of critical care trials, right, are going to that 90-day mortality as the primary outcome. So what was the discussion regarding 28-day versus 90-day or kind of the mortality in general? Like I'm kind of thinking, do we think one drug that you got 90 days ago and you died on day 89, right? I have a hard time like seeing that, but like we're critical care folks, so that's what a lot of that has done.
Yeah, you're describing this tension, right? So in the design of a trial, um, I should start by saying we're following patients to a year. So we'll have mortality at 28 days and 90 days and 180 days and 365 days, right? So we want to record and report all of that. But the question the listener is asking is, how do you strike that balance between a shorter interval and a longer interval, knowing that the longer interval often might be more meaningful to patients and their families, and the shorter interval might be capturing more of the mechanistic effects of the drug. These are medicines that are given once at the beginning of your critical illness. And I think any difference in mortality between these two is likely arising as part of that critical illness. There's no reason these drugs will affect rehabilitation at 90 days or whatever. So I think for this question, unlike if you're doing a physical therapy intervention that's going to extend forever, that should be 90 days or 180 days. For things where the intervention is one time or very short and the mechanistic effects are short, then lengthening that window just allows events that aren't related, and that's just noise. So I think that's where we always have to toggle back and forth on that outcome of assessment timing.
So what are the advantages of having a two-stage trial rather than separate feasibility? Because I think a lot of us you'll see the pilot study, in classic terms, we would have seen the RSI pilot study. That results would have happened, and then you would have started doing kind of this. So, what are the two-stage approach? Talk us through like why you ended up choosing that.
The short answer is, what are the advantages? None. Um, this was a really important question to us. This was a labor of love, and it took us years to get funding to do this trial. That this trial really required substantial funding. So the reason we broke it into two stages, we actually got that first part funded as to prove that we could do the research, and then got the second part funded separately. So if we could have gotten the whole thing funded from the beginning, we would have. So there was not a scientific advantage to this. I think there are real questions. We could have a whole methods podcast on what is the value of pilots, what do they add, when not to do them. But in this case, it was just funding that we had to do this question. We could only get funding for the first part first. And so that's why we did it that way.
Okay, this is a question I've been waiting to ask this question, right? I was compare like EM versus ICU kind of practitioners. It's like if we're doing a verbal meme, it's like Tiger Woods versus John Daly, right? Tiger Woods very clean cut, that's the ICU. John Daly's like very non-clean cut, right? He's got a heater on the golf course, like that's the EM person. Obviously, jokes aside there, but how challenging is it to train some of these clinical practitioners to care about the research minutia that are so important to the integrity of data? But if you're truly thinking of like just treating clinically this patient, you might not necessarily see the immediate benefit of that.
So that interface between the clinical care and the research is what makes this so exciting to me that I think our research all focuses on questions that come from clinicians, right? That this is not basic science research where we have some mechanistic interest that we carry forward. This is just the questions come from clinicians, and that gives us some leverage to basically say, these are the questions that you all found interesting. Help us answer them. And so that's a starting point. But then where the rubber hits the road is obviously this research has to fit into clinicians' practice in a very busy moment. And so we have to be very thoughtful, and we're always tinkering with how do you slip this in so this isn't a burden, that this is interesting and exciting and rewarding. And I think part of that has gotten easier over time, that the first trial like this, it may feel like you're asking clinicians or your pharmacy colleagues or other people to dedicate their time to this. But the feeling of answering a question and knowing, hey, we weren't necessarily doing the right thing before this research, and now our practice incorporates that result, that second question becomes a lot easier. But I think we still, I just have to be constantly mindful of what can we have the research team do? What are we asking of clinicians? And just being obsessive about making sure that we're supporting clinical practice in these environments and getting the results back into practice in a way that's rewarding and makes it part of the reason you want to work at these centers. You could work anywhere, but why are you here? Well, part of it might be we get to generate the results that then make our care better.
These are your patients, right? These are the patients you're actually treating, right? They're not making the argument of these aren't my patients,
Right, exactly.
So you've probably been inundated talking about this, or people kind of emailing ideas and things when you have a study that comes out like this. Are there any like notable questions or ideas that either you or some of the others have kind of talked through as the public has sort of digested and gone through the research that we just kind of highlighted?
This is always a fun phase for me because we put this out that's been a decade in the making, and sometimes we get responses we expect. Sometimes we get things that generate new questions. And I would say the degree to which etomidate is not available in many countries was something I wasn't as aware of before we did this research. One of the reactions that I've been just fascinated by is that a lot of people have said, when I do RSI, this article is interesting, but this isn't how I do RSI. When I do RSI, I don't push the drug. I push a little bit and wait to see the effect, and push a little bit and wait to see the effect, and push a little bit. And before this study, I would have said, well, that's not RSI. You know what I mean?
Yes.
But it has opened my eyes. That's how people practice in a lot of settings. And I've started calling that titration to effect. We've always administered the sedative, administered the neuromuscular blocker, and intubated. And that's not how many people do it. And so I'm thinking about that now. Is there a research question there? Should we be examining that? What are the advantages of titrating to effect rather than rapid sequence? What are the disadvantages? So it's only 2 weeks that I've been thinking about that since these have been out, but that's the one that really has me cogitating.
Okay, I want both of your opinions. Matt, I'm gonna have you go first, but Nicole, I'm definitely gonna have you follow. So have we officially answered this question? Because like you had mentioned, this is the largest randomized. If you combine all of the patients in the other trials, this one is bigger, right? Of enrollees, it's US, multi-center, so many of the things that we like. So do we need more info? Have we answered this question? Where do you stand after being so heavily involved in this idea?
Nicole, I'll answer and then I'll let you give your final word. Um, I think my answer is yes, with two caveats. The first is that there's still a chance that either of these drugs could contribute to a 1% difference in mortality. And um, we don't know. That could be etomidate causes just enough adrenal insufficiency to contribute to death in this tiny fraction of patients, or ketamine causes cardiac arrest during the procedure that we can't detect in a trial of this size. So 1% either way, and that would take a trial of tens of thousands of patients. And there hasn't ever been an innovation trial of that size. But were there one, we might be able to learn that little bit of that's left on the table. Second is, I think we do still need long-term outcome information to understand what are the effects, not just on the short-term outcomes, but on long-term survival and symptoms of PTSD and awareness with paralysis and the other things that patients describe after critical illness that we don't yet know whether these drugs affect. And then finally, I'll say when we say answer the question, I think we've provided the data that clinicians are going to have available, at least for the short term on this question, but that clinicians may apply that to their practice differently. So this may not be one answer for everyone. That is to say, these are the data, but some people might say, well, there's no difference in death. Why would I use the more hemodynamically unstable agent? Whereas other clinicians might say, I still, for various reasons, prefer ketamine and I can treat that hemodynamic instability. So I think having an answer or having the evidence doesn't necessarily mean that this applies in the same way in every setting. Nicole.
Yeah, I would agree that I do think that this kind of puts it to bed for at least a little while. This is obviously the largest trial that we have. We touched on, and Matt, you just mentioned too, that the mortality difference is likely very small. It could be there, maybe not, but if it is, it's potentially very small. And I think, mortality is an outcome, which we also talked about, is that there's so many other things that go on in the patient's care that a single drug that they received 28 days, 90 days, 180 days ago, there's just so many other things affecting that mortality outcome. And I think this provides us with the safety outcome that we didn't have before, looking at cardiovascular collapse and hypotension, that there was just mixed literature on. There was some things showing that ketamine can cause hypotension. There was some things showing the opposite. But I do think the safety outcomes of this trial really provide us with a lot of information to sway one way or the other.
The big thing I want to close with that I think is so impressive, I want to come back to the amazing Judy Jacoby has a quote I like that's like, you should not be emotionally invested in the interventions that you're making, right? Because you can get, the data can change. And
Mm.
you mentioned you all have been working on this since 2017, probably thinking about it years before. And you mentioned there's a whole group of providers that some of them in their mind think they've been doing the wrong thing, and being able to shift your practice style and be able to follow the data and essentially like humble almost enough to like adapt and do that, I think is really unique. And I don't think gets enough credit because like we are creatures of habit in medicine. We don't like change, right? We don't even like if the vial changes, let alone the medicine. So I think it's the people that are able to take this new data and apply it, right, kind of without emotion, using the information that we have, I think is really impressive. And it sounds like this hit the ER kind of groups a little bit more. So if you're doing it, shout out to you, because that change is not always easy. So that's really cool.
I couldn't agree more. In all the research we've done, I've almost always been wrong. So I'm very used to it by now. But I think it is tough to change and to get used to new things. But I think it's a lot of fun, and that's how we improve. We've been doing these trials in tracheal intubation for 13 years, and we collect information on complications during every intubation in our ICU. And what we've seen over time is this line of the complication rate, the cardiac arrest rate, all of these other things going down. So, when we implemented bag mask ventilation, there's a little step down. When we implemented pre-oxygenation with non-invasive ventilation, there's a little step down. Video laryngoscopy, there's a little improvement. And that ability to be adaptive and to change over time, I think is part of what we owe patients, and is a challenging but exciting part of being a clinician.
Nicole, Matt, so unbelievably thankful for you all to come on, not only kind of talk through some of the logistics of this, maybe hopefully debunk a little of some of those things that are floating out there on the websites, but then also just kudos for all the work you all have done in this space, right? Between this research study, your airway stuff, Nicole, you're dedicating probably 300 decades of your life for the RSI guidelines. But in all seriousness, you are the best. Nicole, so glad you're back. Matt, welcome. Yeah, recurring guest, open invite whenever you want to come back. This was fantastic, but really, really appreciate you both. Thanks for all you do in the critical care and emergency medicine spaces.
Nick, thank you so much for having us. And Nicole, great talking with you.
Thank you, you too.